Welcome to ASN Kidney 360 podcast. I'm Sandra Herrmann, a consultant and clinician scientist in the Division of Nephrology and Hypertension at Mayo Clinic, Rochester, Minnesota. Today we'll discuss our study entitled Acute Interstitial Nephritis and Checkpoint Inhibitor Therapy, a single-center experience of management and drug Rechallenge, published in Kidney 360 this January. I'm here with my colleague, Dr. Leventakos.
Thank you, Sandra. Excited to join in the podcast. I am Kostantinos Leventakos, an oncologist here at Mayo Clinic, and have been involved in several studies on immunotherapies. With the introduction of immunotherapy, the average overall survival of advanced melanoma has increased from 16 to 19 months. For my main tumor interest, which is metastatic lung cancer, the 5-year overall survival has been around 5% historically, but recent studies show that in previously untreated patients, 29.6 with PD-L1 expression of 50% or more were alive after 5 years. 25% who had PD-L1 expression levels of 50% or more were alive after 5 years. Unfortunately, some patients develop immune-related adverse events. These complications can occur any time during the immunotherapy. They can affect different organs, including skin, GI tract, endocrine organs, lungs, and liver. Especially for the focus of this paper, the kidneys can also occasionally be affected.
Indeed, it can get very complicated. As a nephrologist, my goal is to improve kidney-related outcomes, but at the same time avoid jeopardize the benefit of cancer therapies. We retrospectively reviewed all cases of acute kidney injury during immune checkpoint therapy at Mayo Clinic, Rochester, defined as a 1.5-fold increase in serocreatinine with a biopsy proven or clinically suspect immune checkpoint therapy-related interstitial nephritis from 2014 to 2018.
1,173 unique patients received immunotherapy over the study period. Of these, 293 or 25% developed AKI. Of the patients with AKI, 14 or 5% were immunotherapy-related AKI. Proton pump inhibitors were used in 11 patients. All 14 patients had their immunotherapy held and 12 received steroids. A complete recovery of kidney function was seen in 62.5% of patients who discontinued both immunotherapy and PPIs.
There was a trend of improved recovery of kidney function in patients treated with higher steroid doses. 4 out of 14 patients with immunotherapy-related AKI were rechallenged with the same immunotherapy, and 3 of them, the rechallenge was successful without recurrence of the AKI.
Our study has some limitations. First, it was a retrospective single-center study, and we may have missed milder AKI events. Furthermore, we limited our search to patients with biopsy-proven AIN or a high clinical level of suspicion of immunotherapy-related AIN and may have missed less conclusive cases.
Our study highlights the need for future prospective studies to accurately identify kidney immuno-related adverse events and their response to immunosuppression. In addition, early nephrology consult is important, and a kidney biopsy should be strongly considered, if not contraindicated. Finally, I would like to stress the importance of dedicated onconephrology teams in the care of these complex patients. There is much more to learn about the immune-related adverse effects of immunotherapy across the different specialties. Thank you so much, Kostas, for joining in, and thanks to everyone for tuning into this Kidney 360 podcast.
This podcast is copyrighted by the American Society of Nephrology, all rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare provider if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.